Good afternoon. This is our final panel of the afternoon. I've stood between a group and lunch before, but it's the first time I've stood between a group and happy hour. So we will proceed along. We've got a very, very august group here today. We're very happy. It's a bipartisan group of legislators. And we wanted you all to have the opportunity to hear the latest from the Texas Legislature and some of the top leaders on the issue of healthcare. We have those of us who are here in Austin and spend a lot of time around the Capitol. We do remind them that we can't miss them if they won't leave. So just a couple of weeks ago, we just concluded our third special session, and there is some very real talk about a fourth. But I'm going to go ahead and kick off here and introduce these panelists that we have here. Representative James Frank serves the people of the 69th House District, which encompasses Archer, Baylor, Clay, Ford, Knox, and Wichita counties. Did I get them all in there?
You got it.
All right.
You got it.
And he is now in his fifth term in the Texas House of Representatives. And Representative Frank serves as the chairman of the House Human Services Committee. Under his leadership, the House Human Services Committee has advanced major legislation that has improved the state's Medicaid program, reforming Medicaid, and more broadly, healthcare in the state of Texas. He has been a constant fixture throughout his time in the office. Representative James Frank. A little further down there, I've got Senator Kelly Hancock, who was first elected to the Texas Senate in 2012. We're fortunate, we've got 3 senators here. We've got 10% of the Texas Senate up here. And only one of them was not House trained, but I will get to him in a bit. But Senator Hancock represents portions of Tarrant and Dallas counties. And throughout his legislative career, Senator Hancock has worked to keep government out of the way of Texas's job creators and has also passed voter ID legislation, pro-life legislation, immigration reform legislation, and state sovereignty legislation. Senator Kelly Hancock. The only not House-trained state senator, Senator Nathan Johnson. In the 87th session, he was active in the healthcare space. He passed legislation, including Senate Bill 1296, to return oversight of the ACA marketplace insurance to state regulators, and House Bill 3121 to open a new tier of short-term residential psychiatric treatment for distressed Texas youth. He also continues to lead the legislative effort to expand Medicaid in Texas. His Live Well Texas plan proposed a Section 1115 expansion waiver and garnered support across the state and the political spectrum, but it did not pass. The statewide political conversation around healthcare, and health insurance, I guess I should say, has however changed, and Johnson plans to continue his efforts on this and many other healthcare initiatives. Senator Nathan Johnson. State Senator Charles Perry is a lifelong West Texan and a practicing CPA from Lubbock. Was elected to the Texas Senate in 2014 after serving 2 terms in the Texas House of Representatives. A lot of us just feel that those House-trained senators, they just do such a better job when they get over there to the Senate. And he is currently the chair of the Senate Committee on Water, Agriculture, and Rural Affairs. He is vice chair of the Senate Health and Human Services Committee. And get this, geographically, he represents the largest Senate district in the state. The district consists of 51 counties and is over 48,000 square miles and is larger than 19 US states and 107 countries. Presents for some interesting town meetings, I'm sure. Senator Charles Perry. And Representative Ramon Romero. Somehow, there was a typo in here. You're Ramon Romero, Jr. At a very young age, Representative Romero was always looking for odd jobs to make his own spending money, given that there was not much to go around in a family of 10. He later washed cars, he did an ice cream parlor job, and he discovered his talents in telemarketing while working for health and life insurance agents, setting up appointments. Representative Romero, not much different than his parents, started his family at a young age, having twins, Lindsay and Lauren, then Giovanni, all before graduating from high school. And while he did attend Tarrant County College, he had mouths to feed and decided to enter the workforce. By age 25, he had started a pool business, A-Fast Tile and Coping, and by 25, he had over 60 employees, many who were from his neighborhood. And today, Representative Romero still owns A-Fast Tile and Coping and also owns Stone Mason Supply, along with the Ramon Romero Corporation. It was his ability to work with city officials in his community that earned a city appointment for Representative Romero, and he later became chair of the Planning Commission. And Representative Romero was also a member of the Zoning Commission there in Fort Worth, the Air Quality Task Force Committee, the Golf Advisory Committee, and various master plan committees. He won the 2014 Democratic primary for District 90 in Fort Worth against an 18-year incumbent. Many of us applauded him for that. And he became the first Hispanic state representative in Tarrant County history. Representative Romero is a well-respected father, businessman, and community leader who believes that success is measured by not how much you have received, but by how much you have given. Representative Ramon Romero. So I'm going to get the questioning started here. And I think just
sounds ominous a bit.
It kind of does.
Get the questioning
look, I put Representative Frank, Chairman Frank here next to me because he is one of the only members ever that we were traveling together, and he encouraged me to agree with him as we were flying on his plane, and perhaps if I didn't agree with him, that maybe I needed a parachute. So I'm going to start with you here.
I don't remember that, but okay.
Listen, for all of you, every session we have a lot of legislation that's filed related to health care and Medicaid and managed care and all this. What I'd like for each of you to do is to just take a couple of minutes and give us your perspective on what the legislature was able to accomplish during this past legislative session, as well as the specials. And then kind of give us an idea of what you think the legislature's priorities should be going into the next session.
Okay.
Representative Frank.
Really simple question, simple, straightforward.
Easy.
I also want to say I always love being on any panel with you because you're the only person that sweats easier and faster than I do. So yeah. So no, I just want to give you a quick perspective, or my perspective, because I'm really looking forward to the questions we can get to. So I've been a legislator for 9 years, and so I look at healthcare through the lens of certainly human services, which were over the Medicaid program, but also through the state budget and what the increase in costs in medical costs have done to the state budget. So those are the two things, kind of the two lenses I've looked at. Also, as an employer, we've got 150 employees, and I look at it from buying medical insurance standpoint. And so those are really kind of the two perspectives I bring. I just say that when I answer questions, those perspectives will come out. One of the real issues I've tried to focus on over the last 3 years is the healthcare costs. When you look at the United States compared to other countries, we have about twice the cost in healthcare as the other developed countries, the other first world, for really close to the same health outcomes. And some of our health outcomes are actually worse. And there's a whole lot of reasons for that, and that's total cost, really, whether it's coming from taxpayers, companies, it's total spend. Is almost twice, and I don't really think anybody intended it that way, and frankly, a whole lot of it is an accumulation of political decisions made literally since World War II. You know what I mean? And so you go back and you see, how did we get here? The real question is, how do you unwind in an intelligent fashion? So that's really what I want. I think from a perspective standpoint, I think way too often decisions are made in healthcare based on the perspective of the politician, the providers, or the insurance, and very infrequently is the actual end user, the 300 million people or 30 million in Texas, that is usually not considered. And really what I think those folks want are three things. They want access to health care, they want it affordable, and they want some amount of control over it. And we tend to focus only on one of those and lose the other two, or we need to and can do that in healthcare. Now, is that easy? Do I have the answers? No. I'm hoping there's a lot of really smart, well-paid people in here. I'm hoping that y'all can help with that answer. I've got some thoughts. But so wrapping up, I think, because I really want to get to the questions and want to hear what these guys have to say. But the legislature, at least the House and the Senate, but the House put together a plan, Texas Families, or Healthy Texas, Healthy Families, And I think focused, as Republicans, really, we a lot of times are not as focused on that as we should. And I think we did a really good job of starting to focus on that. Did we fix everything? No way. But did we make some steps? And did we acknowledge that it is something that we need to do a better job of, and that we have costed people out of health care and access to health care? And we can talk some about that, but passed a fair number of bills giving more choice and hopefully helping the 30 million people in Texas access affordable health care that they actually have some say in. So those are, a lot of things we need to do going forward, but we'll get a chance to talk about that. So,
okay. Senator Perry?
Thank you guys for having this. It's always a good event to be attended to. Specifically in the legislature, we had several things that were COVID kind of related, best and worst practices, I think, when we walk away and look back. But we did expand teledentistry. Not because of COVID, but I think it was a logical counterpart to telehealth that we'd done in previous sessions. We found out that telehealth does work in a lot of settings, and the consumer market's beginning to get more and more comfortable with the idea of telehealth. And as we figure out how to bill for it and get paid on that kind of service, I think that was probably one of the main takeaways, that we had some ideas. Would it work? How far would it work? Could it be utilized? Is the market going to respond for it? And I'll give you, my daughter's 35-ish. She loves to go and have a, quote, internet experience, if you will, regarding healthcare now. I didn't believe it, but it seems to be working. We continued our rural healthcare funding. We started that with Senate Bill 170 in 2 sessions prior. That's critical for rural health care to stay in existence and intact. And to the legislature's credit, we did it during regular session, and then through the ARPA process, we actually extended $75 million of actual rural health care grants, but we also funded some incubator programs for FQHCs. And undeniably, the FQHC model for rural health care, specifically the holistic approach it brings to a one-stop shop for rural health care to keep people healthy so that they don't end up chronic or traumatized by health care needs, is that I think going forward into the next session, we have the FMAP inversion. We added, whether we expanded Medicaid or not officially through the COVID process, we did expand Medicaid. We added, I don't know, the million people that we keep talking about. I don't know if it's a different million people, but the FMAP inversion of that is estimated to be, I think, a $3.5–4 billion cost. We didn't fund Medicaid, as we typically don't, 100%. We carried over $3 billion. So you've got roughly, say, anywhere from $4.5 to $6 billion of, quote, Medicaid costs to deal with before we ever show back up. So I think that's going to consume the oxygen in the world. A lot of that we have to deal with is going to be contingent upon where the feds go. I think the prior panel addressed it very well, that we're in kind of a flux on where 1115s, and we may be forced, the good news is we may be forced to come up with a real free market enterprise solution. And I know Senator Johnson's got a heart and a passion for that, and maybe somewhere in all these conversations something better can come out of it. But coming into next session, and I'll throw in, it's not a political statement, we've got border crossings that are going to probably produce another 200,000 kids in our public school system that we did not put in our baseline budget this year. So the fiscal constraints or the fiscal issues that we face next session are already pretty identifiable and pretty large. Now, knock on wood, fortunately the state budget seems to be holding, but I think that's kind of a short-term look, continuing with if we're relying on consumer taxes to spend in the state budget, consumption sales tax specifically, if there's nothing on the shelf to buy. So depending on how quick that remedy itself, whether or not there's pent-up demand to buy and continue on with cash, that's yet to be known. So, in the current session, we had a lot of stuff come out that were kind of pandemic related, but actually have transformational shifts and ideas. We did clarification, I think, in the telehealth industry. Going forward, I think it's going to come down to it's always a dollars conversation with respect to healthcare and Medicaid and MCO specifically, but I think maybe we're going to be forced to look at some really creative ways. I know Representative Frank has ideas. So maybe we're going to be forced into a box that we're going to actually have to conversation around how do we look better going forward. So I'm kind of excited about it, but I can't underestimate the fiscal impact that I think the state's looking at. If we were budget neutral, if we left the budget zero and we left thinking we're going to be okay, we're $10 billion underwater today with some of the things I've talked about. So it's going to be an interesting session.
It's always good to get the perspective of a CPA on a lot of these things out here. Representative Romero, this was your first session on the House Insurance Committee. Why don't you share some of your thoughts with us as well?
I think the most important thing to understand is that we on the floor, we just talked about healthcare more than we did in previous sessions. And I think the tone and the priorities of members throughout, Democrat and Republican, were that there's a lot that we need to do given the pandemic and everyone that's in the healthcare industry, and kind of walking in with this belief that we have a debt to pay. And if there was ever a session to focus on it, this was really going to be the session to get it done. I know Medicaid is brought up a couple of times. I can recall being on a meeting with Senator Hancock here. We both are from North Texas. He now is my senator for half of my district, thanks to redistricting. Which I love. I'm happy about it. I'm very happy about it. We actually have a really wonderful relationship, Kelly and I. But I can recall us coming into session believing that we were going to have a budget shortfall and thinking, well, maybe this will be the year. And I thought I almost got him to say that he was going to be willing to expand Medicaid. I didn't quite get him there. But regardless of being able to have a senator that's on the opposing party or the opposite party to say that they're willing to expand Medicaid or not, we talked about health care all year long. And when Tony Rose passes a bill for postpartum care and expands it to 6 months, and that's a Democrat that passed that bill, that means a lot. When James Tallarico can talk about insulin and the fact that he's a diabetic, and we can actually cap insulin copay, that means a lot. So I think that as a body, both Democrats and Republicans, we did some good things as a body, caring for not just the citizens that live in Texas now, but those that are moving here. So I think the tone and the tune is something that changed, and it's certainly something that I hope that we continue to move forward, because those are the discussions in terms of, we can't keep doing the 1115 waiver year after year. And maybe we'll end up in that box where we stop giving our money away, we keep it here.
Senator Hancock, you've been quite engaged in a lot of this for a number of years.
Well, and I think that's the point, is that we have, for a number of years, literally led the nation in healthcare reform. I don't know if the federal government would have ever passed surprise billing legislation had not Texas led the way in passing that. Mental health, the amount of impact from the state level on mental health, Texas led the way. So we tend to walk away from sessions. I think the last two sessions you could walk away from it, and if you really looked at the nuts and bolts of what we did when it came to healthcare, go, wow, that was a big healthcare session. But yet we don't talk about it. I don't know if it's because we're Republicans and we don't want to talk about how much we do for healthcare, or whatever. The press just doesn't want to give, that's not the Republican issue, so the press doesn't want to give Republicans credit for it. But if you look back the last two sessions, some pretty remarkable and forward-thinking ideas when it comes to health care. Representative Frank, bring Texas Mutual into bringing a new option onto the table when it comes to health care. Farm Bureau, bring in new option to the table when it comes, because as you know, Senator Perry, rural Texans running those ag lands, running cattle, they look at healthcare and say, look, I'm only going to buy what I need, and I don't need much. Just give me the bare bones minimum. I'm taking a risk every time I climb on that four-wheeler or climb onto a horse and I go to work. Every day they know they're taking a risk going to work, and they just want a bare bones minimum plan. And with the Affordable Care Act, you really didn't have that. Now, I've also been around here long enough that I've gone from, when I was in the House, it was all about reducing the number of mandates on insurance because we know mandates drive up the cost of insurance. But it seems like the last couple of years we've been all about mandates on insurance companies because we want to provide better health care coverage. And we've got to decide what we want to be. We can't push and pull at the same time, increasing the cost of health care through mandates and then wanting to lower the cost of health care. We need to decide which way we're going, not just change direction every 10 years. And so we've seen a little bit of that. So we did have a big session. We rode the dice, I guess, a little bit on some things that are going to be new for the state that they're in the process of coming up with. But we wanted some new options. We wanted some new opportunities because we do believe that this is still a free market system, as limited as it is in the healthcare arena. that by having competition and driving competition and having options, that it will aid the average Texan, whether that be a rural Texan working with the Farm Bureau, or whether that be small, mid-sized businesses working with Texas Mutual for new products that are coming into the marketplace. I can tell you as a small business owner, I cannot take 20% increases year after year after year after year since the federal government has got their hands on health care. And I will close in saying that I do believe, in fact, Senator Perry, I met with auto dealers this week, and they will tell you it's one of our largest sales tax revenue sources is auto sales, and it's been strong. However, they'll tell you that their inventories are drying up. And when their inventories dry up and they don't have vehicles to sell, that's both new and used, that it's hard to create sales tax on auto sales when you don't have autos to sell. And so I do think we're coming to the end of that rainbow, and there's not a pot of gold there, that next session, with everything that we've done that's going to be carryover cost, property tax reform, loved it, big proponent of it, very involved in it, but HB3 is going to carry a cost for years to come. And so we do have some challenges next session based on the foundation that we've planted over the last 2 sessions.
Thank you. Senator Johnson.
Yeah, my colleagues and the whole legislature did do a lot of work. Kelly's right. We've done a lot of work on health care. We passed some good bills. Senator Hancock in particular has led some difficult struggles. I know Representative Frank is very involved in the cost issue, and all of us will be continuing to work on that. For all the work that we have done, it's still been woefully inadequate, and some of it is so dilatory it's embarrassing. Like the extension of maternal health benefits postpartum, like the continuous enrollment of children in Medicaid. With some sad irony, our actions last session may wind up being moot if the U.S. Senate ends up approving some version of the Build Back Better program, at least the components that have to do with those 2 programs, because the federal provisions under that infrastructure bill or the Build Back Better program may actually come and make those things redundant. So we were a little late in getting to that. We have done some good work. We're going to talk about a lot of the other things. As for what we should be looking at for next session, some of the things that we implemented, I don't know if they're going to work or not. I'm excited to see them work if they do. I'm anxious that they might not. I think we need to be studying during the interim whether or not some of the new things that we've introduced are working. If they're not working, what can we do to make them work? Or if they're not working at all, we need to get rid of them next session. So it is important. It's very difficult in politics to do anything new, so I commend the legislature for trying these new things. But I think in the healthcare arena in particular, we tend to make decisions and just stick to them without evaluating whether or not they're functioning or how well they're functioning, and it's very difficult to roll them backwards. Another thing we need to look at is whether or not we want to have a state-based exchange. In that Senate Bill 1296, Representative Frank talked about the ideas of the people in this audience. There were people out in the community who contributed a great deal to a lot of the accomplishments of the legislature last session, including Senate Bill 1296, which I moved through the Senate. Representative Alderson got it through in the House, which essentially took back to the state the ability to regulate the ACA marketplace here. But what if we simply had a state exchange that could streamline the whole process for enrollment all the way from Medicaid to the private marketplace? We could have some efficiencies there. We could reduce the amount the insurance companies pay. We could have some extra money for the state, and we could screw it up. So if we're going to take such an avenue, we should start looking at it right now and evaluate how we do it right. It can't be used for bad. It must be used for good. And lastly, I think we should expand Medicaid. Still, even if the Build Back Better plan comes back in place, you think all those expansion states are just going to give some free money to the non-expansion states? Whatever they give us through the Build Back Better program, they're going to take away from us on somewhere else, somewhere. So at least if we were to expand Medicaid or do something with Charles Perry where it draws down that maximum federal dollars and give it whatever name you want to. Let's look for that so we can get that additional money. And at least as a state, we've got some really good people in our healthcare system. And if we're running it through a Medicaid program, the state has more influence over it. We can have more influence on the cost, the quality, and the health and the patient experience. So I think we have a lot of work to do. Fortunately, we have a legislature that, as Representative Romero pointed out, is quite engaged in the healthcare space right now.
Good. Thank you very much for that. And I want to kind of jump back. And by the way, Senator Perry, Chairman Frank, there is a lady here from Montana that you guys definitely need to visit with, because you want to talk about innovation and other things that she's been a part of. I definitely want you guys to talk to her. Senator Hancock, I'm going to jump over because, as we've been sort of indicating, the last two sessions, we've done a lot here. And as you pointed out, in 2019, you were the driving force behind the Surprise Billing Act. And so it's really interesting to see how we were able to get that landmark legislation through. But in Texas, right now, recent evidence shows that our new arbitration process, the reliance that we have on the 80th percentile of billed charges, it's resulting in payouts that are significantly higher than the average negotiated rates. And so there is a clear indication that there are a lot of large private equity-backed ER physician staffing firms and others that are testing this new law. And the feds have, I think, initially, if I recall, your initial no surprise billing bill included some of the very same things that the feds are including in there, including things about qualifying payment amounts. And then, of course, as you are probably fully aware, TMA has already sued over some of those provisions as well. So for all of you, do you think the legislature should revisit billed charges as a standard and sort of align our arbitration system up with the No Surprise Act, given the impact that, we're using billed charges as a foundation for a lot of this. I'll let you jump in there.
Well, and what I'll point out, and something nobody really talks about in the surprise medical billing legislation that we did pass, because it was a compromise. It was what we initially filed was closer to what we see at the federal level than what we have at the state level. I will say, legislation's the art of compromise. You don't always get what you want. Go ahead and you'll finish the line from the song. So.
But if you try sometimes, you just might find.
Yeah, exactly. And we did try. But one of the elements in there that I think is incredibly important for us to look at as we look at going forward, Senator Johnson, is the transparency piece. And it fits within this discussion in that if you look at the transparency piece, it will tell you what the billed charges have been, what the negotiated rates have been, and what the settlements have been, and the delta between the three. It is incredibly enlightening and incredibly disappointing that anybody would say that billed charges actually mean anything based on the data. And so what we incorporated in the legislation, knowing that we weren't getting everything we wanted, was a transparency piece that would, and we felt like it would at the time we passed it, that it would be the key to future healthcare reform, because it reveals a lot, and a lot of it is not good based on what you see. So I would encourage everybody to go look at it, especially up here, members, as you hear the arguments and debates about why we have to use this and why you need to look at the data, and the data is very, very telling, and the story it tells is that billed charges are way over the settlement rates, and negotiated rates are under the agreed upon rates. And so the more data we get, and the fact that we've saved consumers in the state of Texas literally millions and millions and millions of dollars since passing surprise medical billing. But the transparency piece is huge as we move forward and look at what direction, what information. It will tell you a lot about the people that walk in your office and tell you things.
Sure. Senator Johnson, 1 second, because I saw Chairman Frank. Okay, go for it.
I was just scratching my chin.
Oh, yeah.
But I will say, I'm hopeful that we're entering an age of empirical politics, where just about every question, we set up bills so that we can have some data to look at. We go out to people and we gather information and we make decisions based on that. I'm not sure we've always been doing that for the past 100 years, but we're getting better at it. And I think that Kelly's right. We should look at the data.
My comment was going to be on the pricing. As you study the healthcare industry, it operates unlike any other industry in the country. You have name a retail business where one person can pay $1,000 for a service and another person can pay $4,000
For the very same.
for the very same service. It's not. It doesn't exist. We do transparency. We do transparency. And then you have hospitals literally putting coding on their IT system, on their website, to make sure that that can't be downloaded so that the transparency is not used because they think it's legal to do that. Incredibly unethical, but maybe it's legal, maybe it's not. It shouldn't be, and somebody will have to go fix that law again. It is amazing the level of ethical behavior in the industry. I'm not saying anybody in here. I'm talking about the hospitals right there in some of those cases. Sure. But
I tell you, and this is following on Chairman Frank's point. In my business, in the pool business, we set a price list every year, and we negotiate that price list, and then you better bill what's on there or your bill's going to get cut. And there's no question about it. Occasionally something changes. It's, the job was a little more difficult, the access was a little more difficult, and I'm assuming that's why we get a little bit more money every now and then. But it really is, for someone that's never been on insurance before, to have gotten on this committee and experienced a little bit of what I experienced, it's beyond frustrating. It's not frustrating. It downright pisses you off. Because I come from a district where there's a lot of poor folks, and there was a situation where what was being billed was not even close to what was negotiated, not even close. And then to find that some of these companies still write off the loss, I think that's theft as an American. And I think about the young people that approach me that made a mistake of putting a toy in their purse at Walmart because the kid wouldn't stop badgering mom about it. So we put somebody away for stealing a $10 toy and change their life. And then this is going on in the industry, and I don't know that some of the industry has been shook up enough, And so those of you that had to deal with me on insurance probably felt like I shook too many people up. But I had to get over that level of ignorance, and then get over that level of frustration, and I hope that as we go about, we only serve the people of Texas, and getting to a system that's repeatable, that's empirical. Is where we have to be, and I pray that this is where there is no party lines so that we can continue to move forward and serve our state.
Did you want to add anything?
I'm just not going to worry about it. The feds are going to fix it, right? So
No.
It's really unfortunate that we allowed and built a system, probably in its inception, that volume and all of those conversations about procedures and the type of procedures and expertise, the specialization, but then we consolidate to a point where there's really no competition at some level. So the bottom line is I think Kelly's bill did a great thing. I think the feds are sitting the same pressure as we are. You're seeing that in an insolent conversation that's ongoing at the federal level we've had here. You've got the PBM conversation going on at the federal level that we've had here. So there's enough frustration at the political level now that just maybe everybody's gotten mad enough that they'll do something about it. But on this issue specifically, I would caution two things. One, I think ultimately we will get to where we want to be with respect to the deltas and the changes in actual cost of service, and that's been a challenge to find because of creative bean counters like me. And secondly, I think that we did have a COVID area, and I'm probably the most anti-COVID conversationalist you'll find, but a large part of these costs, if you will, were ER, and then even outside of COVID, a large part of these costs are private contracted ER nurses. I don't mind saying it, I've got private ER contracted nurses in rural care making $500,000, serving 3 or 4 hospital systems in my region because free market. We all like the free market, right? It's working. They got to pay $500,000 to that person to serve those areas. So, if you really want to get transparent, I think you almost have to kind of break it apart to see where the abuses are, or perceived abuses, and then put it back together with a plan that kind of addresses all. But, it's kind of like the dike. You kind of fill up a hole here, and then all of a sudden something comes out here you didn't see. And we're playing whack-a-mole. And so I think as well intended in where we're going to get to with that bill ultimately, we're just finding now that there's a few whack-a-mole still to go after.
Yeah, I will say I've always found it interesting. We do have a statute that requires auto mechanics to post their hourly rate right there on the wall for everyone to see, but there is no such requirement on the physician side. So, and kind of as a quick follow-up to that, the No Surprises Act, it also includes a prohibition on air ambulance billing in its consumer protections, but neither the Texas law nor the federal law include protection from ground ambulance. And I think, Senator Hancock, to what you said earlier, a lot of this is about what's doable, politically speaking, and we all understand, and there's a lot of us here in this room who attempt to influence things one way or the other on some of these things.
I'll play the devil's advocate on
Sure.
that. The average age, I think, of an EMT or an ambulance driver in rural Texas is 60, maybe. We can't get people to fill it. We did relieve some regulations requiring 2 certified people driving in that ambulance at one time. But, you know, if you're hauling somebody for 68 miles to get them to Lubbock or Abilene or wherever the hub area for medical services are, it costs money. And you don't want to have a discussion or a decision point that says, in order to get Joe saved, I've got to travel, but, you know, I don't know if we're going to get paid on that. And I don't say that it's ongoing there, but I think when you have those conversations, you truly got to look at your rural healthcare system independent of someone that drives ambulances across a geographical city limits.
That's a fair point. Yeah. Anyone else?
Well, I mean, we filed legislation on it. The difficulty there is because we had some very egregious things that were not rural health care, moving from one hospital to another that was not 65 miles away, with extremely high billing taking place because there is no accountability, oversight. The difficulty you had is not only stepping on the toes of a profession that likes to do whatever they want to do and bill whatever they want to bill, but the agreements they have with their local municipalities. Now you've got the municipality fighting you as well, and we weren't able to get much traction on that.
But we were able to pass a bill that studies the issue because it is more complex than perhaps some of the other areas. Senator Perry brought up one of the issues. We do have some egregious examples. It's generally bad when a few egregious examples drive a whole policy. I think that overwhelmingly likely sometime during the interim, people are going to come to a consensus over what that bill should look like, and we will pass it next session. The federal government's studying the same thing. They're having a hard time. It is a complex issue. I think the conversations got very close during the session, but not all the way there.
Well, I mean, there's anecdotal evidence of people actually calling an Uber or something to get them there rather than an ambulance because they see the price that comes with the Uber, right? So. And Senator Perry, you brought up something here.
But don't trust your Uber driver to provide emergency medical care on the site. Just so you know.
Pretty soon there may be a doctor or two behind that Uber wheel, right? Yeah. So, Senator Perry, you brought up something specifically about insulin and other things. So let's turn our attention a little bit here to the drug price question. And this past session, the legislature passed Senate Bill 827, which capped a patient's copay for insulin at $25 for a 30-day supply. However, and this is the trick that we always find ourselves in, right? It only applies, well, but it also, in addition to, it just transfers the cost, but it only applies to those folks who are in state-regulated plans. That's a fully insured plan, right? So it did really address the real cause of why long-standing drugs like insulin and others are getting so expensive. I mean, the price of insulin continues to rise without any major improvements to the drug. There are 3 companies that control 95% of the insulin market. So there's been a number of laws that have been enacted in various other places, and California has some very specific laws, and you know, I'm kind of reminded of that old Pace Picante commercial where they say, New York City, get a rope. I mean, I know now bringing up California, we're not California, let's be clear about that. But, you know, there was some discussion last session in the Texas Legislature that was considering a different approach with regards to preventing some of the payments that go to the generic manufacturers and others. What I really want to hear from you all is, do you think that addressing this issue of underlying manufacturer prices in general, or patent gaming, which is what tends to happen with a lot of that. Is that something the legislature you think might have an appetite for either next session or any time in the future?
Yeah, I can tell you straight up, yes, and definitely yes. I had an amendment that would have effectively done probably that to a bill that Chairman Kolkhorst had put on the floor. If you want to get the attention of the industry and the lobbyists that represent them, just file a bill in the insulin market. You'll be a popular guy really fast, but I did not, that was not the reason I pulled it down. I pulled the amendment down for this reason. I was assured, I was guaranteed that there will be generic insulin products on the market before we get back to session. They said 6 to 12 months, their clock's running. I gave them 18 as a courtesy. But come 23, if we don't see the generic market alive and viable, I think you will see the legislature get engaged. Now, I'm not sure that limiting out-of-pocket costs is the answer. You heard the counter. That just means that insurance companies are going to bore more. And so I don't know that we had all of the data to make an informed, reformative decision. What I do know is that there is gaming, the evergreen concepts, tweaking a formula, buying out your competitor, and the way they, just the use of insulin at some level would get you a lawsuit because that was, quote, not generic enough. I mean, it's just a weird industry. They've gotten by with it way too long. It's a drug that people need to live on. And it's a drug that people are having to make a decision, do I eat today or do I use insulin today? That's unconscionable in our society. We're too wealthy of a nation not to be able to take care of those issues. So I have no doubt that if there's not a viable generic market, and depending on what the feds do with this, because it has now risen to their level, that we will make reforms that will be good for consumers. I hear the word transparency in a lot of things in the healthcare industry. And if you ask one of these guys talking about it, it's like, we're going to do it so the consumers can save money. If I hear another technology or transparency initiative, I can promise you experiences, consumer will pay more money. So the game is up for everybody that's in it. Scams out. We're done with it, I think, as a legislature. We're going to, I think, roll up our sleeves and get some things done. On the insulin, yes, sir. There's going to be a reform if they don't come to do what they said.
I hope, and the drugs are very complicated because you have the feds and the state, and the feds control much of that. I do think there's some things that we can do as a state on that, because really what you do have in many of these cases is you have 1 or 2 or 3 players that are effectively controlling the market, and there's no antitrust. And actually, that's one thing I think we can have some very bipartisan support on. I hope. I love a free market, but when you don't have any competition, you don't have a free market. Right? Mm-hmm. If you don't have transparency in pricing, if you don't have any competition, and if your customer doesn't care how much they pay, there's no way to have a free market, right? So what you have is you have a couple of cabals deciding how much we pay. It's embarrassing when our country is paying 2 and 3 times, our people are paying 2 and 3 times more for the exact same thing that's overseas. The exact same thing. There's some of the COVID testing stuff. It's $24 here, it's $4 there. That is embarrassing. Do I know how to fix it? No. Not exactly. I think there's some things that we can do from a prescription drug. We may have to do them only in Texas for Texans to avoid that, and that may help the feds do that, because they seem to get, no matter, and this is bipartisan, get out negotiated by the pharmaceutical companies, because the money is not going to R&D. The money is going to the stocks, period. And I love me some free enterprise, but there is no free enterprise in those areas.
Exactly.
I think one of the things that we shouldn't forget is this is the first year, this last year is the first year in my 27 years in business that I couldn't afford health insurance for my employees anymore. Wow. Because my second employee got cancer. And they kicked me off. I'm too expensive now. And maybe I needed to go with one of those bottom dollar health plans. But a successful business can't afford health insurance anymore. And then some of those employees that had it with me before, now they didn't go into the marketplace. They didn't get Obamacare. They didn't get the ACA. So now they're rolling around without any coverage whatsoever. And one of the things that can't be left out is these folks probably aren't getting insulin. and they're showing up at our hospitals, and they've got diabetic shock, and it's costing us over $20,000, every single one of us. And as a state, that's where we need to always, regardless of how it's affecting those that do have insurance and the policy changes that we can make, we still can't forget about all those people that no longer have health insurance. And those are our people. In this case, these are my people. These are my employees. And it's ultimately still costing every single one of us because we're not doing enough fast enough.
It kind of reminds me of the old monarchy thing, right? You can pay me now or you can pay me later, right?
Well, and it's specifically hitting small and mid-sized businesses. I mean, when I compete for hiring employees, and I'm competing there's 2 large international players in our market space, and I have to compete against them, and they have thousands of employees. They kill me when it comes to insurance cost. Kill me. I have to have it because I got to compete. If I'm going to hire from my competition, I'm going to be competitive in the workforce. I've got to have that. I got to have retirement. But it's killing me as a small to mid-sized business. And you can't compete with the ones that have the large volumes because if you've been loyal to your employees and they're older, you get killed pricing-wise. And I will tell you, in our industry, in the chemical industry, which is a kissing cousin to pharmaceuticals, 7 years ago, the federal government was very, very quick to jump on foreign imports of a particular product, file a lawsuit, charge them with anti-dumping for selling too low in the marketplace to protect local manufacturing, domestic manufacturing. But they have no problem letting insulin costs continue to rise and rise and rise without competition. They're gonna come sue you if you sell too low because it might hurt some of the large manufacturers in the country. But if you're selling too high, there's no lawsuit.
There's nothing against that, right? Senator Johnson, did you want to add anything?
No, thank you.
Okay. Well, just so you know, I was in a discussion last week. There's a $2 million drug for a single dosage of this thing that I learned about last week. I was just stunned to hear about this. So we've had a lot of conversation. There's a lot of mention up here today about provider transparency. Throughout a number of the panels, there's been a lot of discussion around provider transparency, but both the feds and the state have recently increased the amount of transparency for health plans and for hospitals, but physicians have not been subjected to that very same type of transparency requirements. And it's widely agreed that these charges and prices of the physicians and other providers are the primary cause of some of this cost growth. Do you think there's a need to increase physician and provider transparency in order to provide consumers with better access?
I'd say anytime you can have transparency, a good thing. I think it's interesting the conversation about transparency is it's a little one-sided, depending on who's asking for it. So when I say I'm about transparency, if I want provider transparency, that's okay. But remember, most of these providers get reimbursed by private insurance, state contracted Medicaid, or private pay, which may or may not have such a transparent look on pricing. So you can argue that they're billing a bunch of stuff, but they may not be getting paid on. But the bottom line here is, if we're going to have transparency, I want PBM transparency. I want MCO transparency. I want hospital billing transparency. And then we can have provider transparency that says, yeah, here's what I charge, but I charge this because I've got 8 people in the back that chase all the billing practices that each of you guys require me to do in the insurance industry, in the MCO industry, in the whatever industry. So for every billing stream, they have at least one person that's a master of that billing stream to know that they check the boxes right to get paid. So when we talk about transparency, it's not for a group or a purpose. It's for our benefit as policymakers to know where are all the secret sauces in the boxes at. Because you can't just say you need to be more transparent, but not me. Because until we get that, where everybody across the board's come clean and allow the consumer to make a choice based on that, we're never going to fix this issue, or at least we're not going to know how to fix the issue. But I'm for transparency, but I'm not for a group's required transparency over another group's not required to do it. It's a whole thing for me. Everybody gets to have a bite at that apple if we're going to go down that road.
Senator Johnson.
Yeah, where I think it may be particularly relevant is consumers who have high deductible health plans. If you don't have a high deductible health plan, or if you've burned through your whole deductible, you're not really that interested in what the charge is. So from the consumer, you're not going to have that kind of price control on the consumer side. But you do in many, many cases, and you have physician referrals, primary care physician referrals to specialists, and the primary care physicians aren't aware of what the specialists are charging, and there may be quite a variance, and they don't have the time or the resources to go research everybody. So if there were a way for primary care, the referring source physicians, to have a better sense of who's charging what and what kind of quality outcomes they are having, they can then be part of the control process by steering their patients to specialists who are charging fair prices and delivering good quality outcomes. I don't understand how to do that either, but I understand it may be, since we are moving more and more towards a managed care model, not just within Medicaid, but in the private sector, we're kind of moving that direction as well. We do have referral sources, so a free flow of information among the referrers might be useful in controlling cost of quality.
So yes, I think transparency, and I think Senator Perry's point is true. It needs to be everyone, because, and honestly, the insurance as well. There's a legislative report, just so y'all know, there's a legislative, I'm sure y'all do know, that tells you, here's what you got in premiums, here's what you paid out to providers, here's what you paid out to pharmacies. I asked a question when I was looking at our renewal. I said, well, of our provider, I said, well, is that before or after rebates? If your purpose is to intentionally mislead your customer, in my opinion, you're part of the problem. And I think that's where, as an industry, whether it's pharmaceutical, insurance, that kind of stuff, we've gotten to the point where we don't ask what's right, we ask what's legal. And that's a load of, that's not cool. It's really not where people should be as an industry, but yet that's where, to me, that's where the medical industry is. It is. You almost need to take a shower after you get finished looking at it.
And I would add that one of the things I think that you all can help with, and that we can help you understand, are the things that we see that we don't believe contribute any value into it, but by statute or by regulation, we're required to do this, right? And we know the provider abrasion that it causes. And so I would tell you, from our perspective, we've got to do a better job of saying to you all, hey, this doesn't add value. It only brings about provider abrasion. If we can do something to be able to satisfy both the state and the feds with do this, let's get rid of it, right?
Yeah.
Because it'll save money across the process. So I do want to, we're almost at time. I do want to see if there is one or two questions out there. Oh boy, look at the hands flying up. So we do have one or two questions out. Jamie, I think we've got somebody over here.
Okay, I think we'll just do one question.
Okay, we've got time for one question.
Hi there. So in this panel discussion and several others throughout the day, there's been a lot of discussion about the need for flexibility for employers. And we hear what Representative Romero was talking about, his situation with his employees and others, and also the need for the consumer, the ultimate consumer, to care more about the cost of healthcare. Is there interest in really pushing some of these new models that would strengthen the individual market a little bit, like individual coverage HRAs, where consumers can, through their employers' offered benefit plans, make these individual policies more competitive and cause the carriers to kind of customize those plans a little bit more, and then sort of put a little bit more pressure on the healthcare providers, in turn. And also, if the consumers have choice in those plans and the ability to save some of what the employer is contributing, then in those extra dollars, they also care about how that money gets spent, as they can save and make decisions.
Sure. Very good question. The first thing I'm going to throw out there before Senator Perry jumps in is, I think per the discussions we've had here, as well as some that you've had today, that structure right now to provide those consumers with what they need may or may not exist just yet. But they're coming. I think to Senator Johnson's point, we've got to be a lot more data-driven and focused. So Senator Perry.
What she described was healthcare before government got involved in it. That used to be the plans you could get, right? Everybody just bought what they needed. Farm Bureau kind of opened that back up. But back in the day, it was a single male that was never going to be pregnant bought a single male policy. A lot of those things. And then and to the industry's credit or discredit, I don't know, because they're not transparent. I don't know how much of their cost or risk sharing goes on between covering maternal problems with the single policy that used to exist. So until the industry can provide data that says we have to have a pool this big, it has to be inclusive of all these people and all these issues to make sure that person's covered, or we can carve it out, but all of these people, I mean, I guess what I'm getting to is we can't help fix the problem if industry groups themselves, and there's a niche market for that very much policy, if we allowed it statutory regulated to go out and do it, but then you're going to have the industry scream bloody murder, you're taking the healthy people out. So yes, that was where we need to go back to where it is an a la carte provision, where people with wealth can afford it and where people that don't need it don't pay for it. But the industry groups have argued that they need the actuarial soundness of including more of all spectrums to make sure that those that can least afford to be on those individuals get coverage and those that can't afford it don't care. So I just need data.
It doesn't work. In a business environment, it doesn't work. I can't sit there and say, I want you to be one of my employees, but you better be pretty healthy. If you're not healthy, I can't have you on my team. You know, it doesn't, because if I've got a good employee and they've been with me 15 years and all of a sudden they have cancer, I can't go to that employee and say, man, I'd love for you to have a job here, but the way we do insurance, you'll never be able to get it or afford it.
To add to that, as an employer, I can't write the premium check for an individual policy for an individual and have a group over here. I can't write an individual check for an individual's policy. Now, I can raise their salary with taxes included in it. They can go buy their own, but you get into some weird discrimination issues. I mean, the feds have regulated this into a pretty tight box.
And you still have to compete. I mean, I'm still competing with international companies that I can't say, well, this is a good policy, but this is all I can do. I've got to compete with my competition.
Senator Johnson, you
One other point on these issues. When you're customizing health plans, and we did introduce, and I'm all for exploring alternative models. I once had an employee tell me, I don't need pregnancy coverage. Guess what? She did. Let's be careful when we're customizing. I don't need this, I don't need that. That's why we have regulations for these things. It can be overdone. It probably has been overdone. But let's proceed cautiously before we start deciding that consumers are definitely going to know exactly what they need, particularly when they're saying, ooh, it costs that much extra for the high fidelity stereo. I don't need it. This isn't a stereo. This is coverage. Just let's be careful.
And so as we prepare to end this, I'm just so glad that I had the opportunity to do what no one should do, is to get up and talk politics in a large group. So first of all, let's give a round of applause to our panelists today.